Good evening, everyone. I hope you can all hear me. A big welcome to all the people who have registered and signed in. My very pleasant job is to welcome you on behalf of the London and Southeast branch of the Institute of Physics. I shall introduce myself. I am Rizwana Shelley. I'm the Education Officer for the London Southeast branch of the Institute of Physics. We do a lot of work with supporting infant, primary, secondary schools, universities, as well as young researchers, young industry works, and mid-career physicists and STEM workers. But the pandemic has put a hold on that. But we have been very innovative. We have started webinars and reached people across the world. We have also not been able to go into schools, which was a big part of our work, but we have made very good connections with people on the ground, like food bank people and the other associations that work with the hard to reach people and people in the lower socioeconomic group, and also the groups that go and help children in the holidays, like sports clubs. And we have found a good way of reaching the influencers by sending Marvin and Milo booklets. And I will show you one I've got in my hand. They're only about this big, so they're not very big. And there are 7 or 8 cards in here. These tell you how to do experiments with the stuff you have at home. And we also send that, with that, we send the IOP branded equipment, very important, pen, rubber, pencil, ruler. There's a nice pen. They're really good IOP pens. If you come to lectures, you'll be able to get hold of them. And we have had very good feedback from that, because the influencers are getting the stuff delivered to them via the channels that already work. The format for the evening is, once I introduce Dr. Kennett, there will be a talk, then there will be a chance for you to ask questions. So please do put your questions on the chat, and then the organizers will ask the questions. Now, my very pleasant job is to request that if there are anybody in this audience that would like to volunteer, please do volunteer to support the London and Southeast branch. We do everything to help in any way we can, our communities where we are, where the volunteers are, and there is a lot of good support. So please think about it. How little and how often is up to you. But if you send your name to the contact, which will be up in a few minutes, and at the end, then we can hopefully recruit some volunteers. Now, my very pleasant job is to introduce Dr. Craig Kennett. He is an outstanding dental specialist and general practitioner at the Dental Hospital in Kent. He is a particular expert on the gums and jaws that support teeth. You will hear and learn a lot from the talk. I've had a preview. It is really good. I got to know Dr. Kennett through his voluntary activities, and they are amazing. If I start talking, the whole lesson will go, the whole hour will go. And he has been both a trustee and general secretary of Kent Muslim Welfare Association for 17 years. He is also learning Arabic. His accent is better than mine. He loves cooking, and he volunteers. And more to the point, I know that last night, 10 o'clock at night, he was collecting food from the local co-op and delivering it to the homeless. So I shall not be in the way of you and the talk. Dr. Kennett, it's all yours.
Thank you. Well, thank you very much, everybody. First of all, I'd like to thank Rizwana, and I'd like to thank Amy and everybody at the IOP for giving me the opportunity. I hope you can all hear me okay. If there's any problems, please let us know. Today, I want to talk about teeth, titanium, lasers, scanning technology, and show a little bit how the application of physics has helped to shape modern day dentistry, or certainly the dentistry that I do at the moment, which I hope is modern day. So let's get on with the talk. The scope of the talk is going to be talking about dental implants and cone beam CT scanning as an aid to look at and analyze cases particularly for dental implant placement. Digital scanning to help make, for example, the teeth that go on top of implants, and to also look at some of the CAD/CAM technology involved in that, and lasers, the use of lasers, which is a separate thing, and show the application of how we might use lasers in dentistry, or how I've used lasers in the last few years. There's quite a lot to talk about, so it'll be a bit of whizzing along. Also, the slides, some of them are a bit gory, so if you have a disposition whereby you don't like to look at gory pictures, I'll try and sort of warn you in advance, and you can maybe peek at them or not look at them for too long. So I'll carry on. This is where I work. It's quite an impressive building. It's on Bluebell Hill, Chatham, Kent, and it's the Hospital Lane Dental Clinic, which has recently been acquired by Bupa. So it's now a Bupa, what they call a Bupa Platinum practice. A very nice practice. I've been lucky to work there, and has afforded me this sort of opportunity to work with these different technologies. So cutting edge dental technology we use at the clinic. Now, obviously, we're here to preserve teeth wherever we can, and this is a little bit of a, as I say, gory. So the first gory slide showing teeth. If I can use my arrows, and you can see my arrow. So we've actually got the crowns of the teeth and the roots of the teeth, and then the bone underneath. The gum has actually been pulled away, and teeth can become decayed, so therefore needing fillings. That's a very old-fashioned amalgam filling, a composite filling. They look quite old, these fillings. So we can restore teeth where they're decayed, or sometimes even the nerve inside the tooth dies off, and we have to root fill the tooth. Or what also happens is some people can get gum disease, a disease of the gum tissues and the bone, where the bone erodes away. And if you lose too much bone, for example, then that tooth may have to be extracted, and you end up with a gap. And you know, the gap, you may get away with that. That may be in a place where you're not too worried, but if it's at the front of the mouth, or if it's a chewing tooth particularly, then you may want to replace that tooth. And so we lead on to dental implants is a way of replacing a missing tooth. That is a tooth where you've lost the crown and the root of the tooth. Now this slide is scanning electron micrograph showing an osteoblast, a bone-producing cell swarming over the surface of titanium and producing bone. And it's a very iconic slide. There was, I think, taken in this photograph was taken in the 1960s, showing the ability of bone to fuse to titanium, and the titanium to integrate into living bone and become part of living bone. And this was very important for orthopedic surgery initially, and dentistry was sort of piggybacked on the back of orthopedic surgery in its ability to actually put things into living bone that would stay there, and then you could attach things onto that would connect and become part of your body. So what is a dental implant as opposed to any other type of implant? Well, a dental implant, the implant itself is the screw, the titanium screw. You can see half of this is an implant, half of this is a tooth. And the dental implant is a screw which is screwed into the jawbone, which replaces the root of the missing tooth. So this would be the root. This is actually the implant. Everything else on top we don't really call an implant. This bit that fixes into the implant is called an abutment, and then the thing that goes on top of that either cements or screws in is called a crown. So that this may be one piece, and there may be a hole in this where a screw goes through and connects the whole thing. Or you might have two pieces where you've got an abutment that screws in and the crown that fixes on top. You have to compare this to a natural tooth, where a tooth is actually held in to the bone by a ligament. So this is a fibrous ligament of 0.3 millimeters roughly, which contains nerves and blood vessels and fibers that connects. So this can actually move. You can wiggle a tooth about and you'll actually get some slight movement. Whereas when we come to the implant itself, the implant doesn't move. The implant is ankylosed or fixed connected to the bone, and you can't wiggle it around. If this implant moves, it has deintegrated from the bone and needs to be removed. So whereas we can slightly move a tooth, we can't slightly move an implant. And then if we look at the x-ray here, then we can see that there's a crown and there's the implant in the bone, and the crown connects. And then if we look, this is actually the crown here. It looks quite nice. If your technician's very good, they can make a very convincing crown, which looks like it emerges from the gum, and you know, you can't tell the difference between the crown and the tooth, and that's what we aim to do. Now, if you have missing teeth, there are several options. Do we always have to place an implant? No. If you like, old-fashioned way or cheap and cheerful way is to use a removable partial denture. So this would be acrylic teeth on a chrome framework, or sometimes it's all acrylic. But this is removable. You know, you take it in and out. It's not fixed. It doesn't feel fixed. Fixed solution could be to use the teeth. So if you have a gap and you have natural teeth, you can cut these teeth down into stump shapes and make teeth connected to two crowns that you then cement on as forms of tooth supported bridge. Or you can leave those teeth alone, which is obviously an advantage, especially if those teeth are natural teeth, never had any fillings or anything. And you can put an implant either side, and then you can make your bridge or connect your teeth onto implants. So these are the choices when we have missing teeth. If we actually want to restore those teeth, this is what we can do. So just to go forward, anatomy is important. Anatomy of the jaws. We take an x-ray like this just to give us an idea of the anatomical shape of the bone. So just to sort of, this is the lower jaw here, this is the upper jaw here. These areas here, here, and here are air-filled spaces. They're sinuses here and here, and this is the nose, floor of the nose here. So the upper jawbone is very narrow, and it only forms a very thin part here. So if I wanted to put an implant into this space here, we've probably got about 1 millimeter bone height, which is not very much at all. Whereas if you want to put an implant here, we might have something like 20 millimeters of bone height, which is more than enough. Down here is if you can see this sort of tube running in, or structure here, you can actually see it on this side better, tube structure here with a hole in the middle. This is actually a nerve running inside the jawbone. The nerve exits out at that point there. If I'm putting an implant in the back here and I actually damage that nerve, then the person will have a numb lip, either temporarily or possibly for life. So we want to avoid doing things like that. We have to know where the certain anatomical structures are. We need to know the heights of bone so we can plan our cases, but we also need to know the widths of bone. And this information is, although it's very good, it's not really enough to give us all the information that we need in order to plan out implant treatment. So we now use, you know, I wouldn't do really any implant treatment without taking a cone beam CT scan. And this is gives us sort of more of a 3D image, as you can see. The CT scan can allow us to place implants virtually and decide where the best places are. And as I was saying, here are the sinuses here and here, so there isn't really much in the way of bone there. And the only place that we can place bone in the upper jaw is between this point and this point, unless we do some form of grafting. And I'll speak briefly about grafting with a few gory slides in a few minutes. How does a cone beam CT work? So it's a bit wordy, but it's a nice summary. The X-rays, it produces X-rays, and they're generated by an X-ray tube. This rotates in a circular trajectory. You often hear when you read about this about a C-shaped arm gantry to help the X-ray tube move in a C shape. It generates a cone-shaped X-ray beam, which is captured on a flat panel detector, and basically the X-ray photons are converted to light photons, which are converted to electrical signals. So during that rotation, the cone-shaped X-ray beam is captured several hundred times as many two-dimensional X-ray projections as in the raw data. And then you've got some nice software which then reconstructs that into a three-dimensional representation of the scanned object. So we end up with something like this, whereby we've got this sort of representation 3D, which, to be honest, most of the time I don't really use this sort of view. The views I will use is this sort of view here and this sort of view, and then sometimes when I'm placing the implant, this view. So what this is, we're looking flat on, face on here, and this is the same image but a small portion where this red dot is around here. So we're looking at this area, and then if you imagine that this is a loaf of bread and each of these small lines are slices, and we can take one slice of the loaf out and turn it at 90 degrees and look at it flat on. That's what we see with the top image here. This is a slice like this line here, taken out and looked at in this direction, looked at flat on. So we can see in profile, the nose would be here, the floor of the nose is here, so the nasal passage is here. This is the lip, and then the chin would be down here in profile. These are the teeth biting upper and lower end onto a little jig there, and then this is the palate. What I'm looking at here, I'm looking at the root of the tooth, the crown of the tooth. This tooth has been root filled. The root canal has been filled with the material, and this is the bone here. And you can see that there's actually a canal which runs between the top. So this part here is just behind the two top front teeth. So it's just behind the two top front teeth, and that canal runs to the floor of the nose, and it's called the Nasopalatine Canal, and it contains lots of nerves and blood vessels. So that canal contains lots of nerves and blood vessels, runs up into here. So, you know, if I was going to place an implant, this is the available bone that I would have to measure the width and the height. So the height I would see on that flat X-ray that I showed at the very beginning, but the width I can only get from this sort of CT scan. And then it shows me other things. So you can see here, the bone is very thin around this tooth. So these are considerations that we have to take when we're planning cases. But it does allow us to plan a case whereby we can remove a tooth that needs to be removed and place an implant straight away and restore that tooth, at least with a temporary crown. So this has now a temporary crown on. So patient comes in on the same day with a tooth that needs to be removed. The tooth is removed, and then the tooth is replaced on the same day, and they have a temporary crown, which then later on is replaced with a permanent crown. It also allows us to analyze bone and try and get the best out of the case. So we can look at bone structure and see where the bone is and where it isn't, and try and come up with more conservative ways of doing the treatment. So where we don't have to, for example, place a graft. So this is treatment options, graftless procedures. You know, the CT scan helps us do that. Now, sometimes, though, we can have defects around an implant. So this implant, this is quite an interesting slide, because first of all, it shows the implant shape in more detail. And implants, when they were first made, were machined. So they were machined, shiny surfaces, and they suffered from a lack of integration because the surfaces were quite shiny. So what happened was that in the development of implants, the implants became more roughened, and also they didn't just become more roughened, but they, you know, some of the threads, these are quite aggressive threads in an implant. So the disadvantage of aggressive threads is that if this becomes bacterially contaminated, then the bacteria have lots of little niches to hide in, and cleaning the surface of that implant becomes very difficult. And you can get tissue destruction and degradation around this implant. And then that leads on to having to treat the implant in a specific way, which I'll talk about later on. But for now, the shape of the root is often different to the shape of the implant and where you want to put the implant. So here the root was like this shape here, and then where we want to put the implant leaves a defect. So you can fill those defects in with bone graft material. But sometimes we get these problems due to disease as well. So this is where we have severe bone loss. So these teeth had lots of bone loss due to gum disease. It's decided to remove the teeth and replace them. And sorry about the other, next set of gory slides, is actually these teeth were removed. The gum is pushed back, and you can see the shape of the bone. It looks like sort of craters of the moon. And here we have again lots of very thin ridge there, too thin to place an implant, thicker ridge but no bone. So what do? We clean this out and we fill these areas with a graft material. And this graft material is basically inorganic, deprotonated, crunched up cow bone. And it's a space filler. So that's all it is. It forms a scaffold for which new bone can grow into. And then on top of that, you place a collagen membrane. And this collagen membrane is porcine, it's basically pig derived. But this collagen membrane is placed over that to help hold that material in place. And then the gum is placed back over and is sutured up and allowed to heal. And this is 2 weeks after surgery. You can see it looks a bit wobbly. You can see a little bit of the graft material, excess graft material coming through. But this is 4 months after surgery. You can see you've got this nice, well-rounded, well-thickened jawbone. And if we look at what's underneath, you can see that has healed into a really nice bone where you can place your implants into now. So it just shows you the scope. The bone can be regenerated sometimes when you don't have enough bone. Sometimes it works nicely. Sometimes there are lots of different ways of doing it. I've just shown you one way there that works very nicely in this case. So before and after that. And what we would do, the old-fashioned way of doing treatment is, if there are missing teeth, we would take impressions using usually an alginate type material, and we would get the stone model made. And then onto this stone model, the technician would fix some teeth and make a diagnostic wax up of the place where we would want to ideally put the teeth. And then using that diagnostic wax up, we would then take an X-ray. And the original X-rays, the cross-sectional tomography, they were called scanoras, produced these films. And these are like the shiny films that you know, more sort of old-fashioned rather than digital images. And you'd have to have some form of marker there of a certain width that you pre-knew. Say this was, for example, 3 or 4 millimeters. And then you would be able to use that as a template. You'd have a ball, usually you'd put a ball bearing in there, or you could use the size of a tooth. And then you could use that to measure as an index or a reference to measure how the width and height of things. So that's basically how. So there were different ways of doing things. That's basically how you would do it. And then you would place your implants, and this is what the implants would look like. Implants have different appearances. There are different makes, models, shapes, sizes, slightly different appearances. But generally, the implant is in the bone. The gum sits over the top of that, and initially the implants have healing caps that sit on top. If you're not going to attach your tooth straight on, you would then take an impression of that. And sorry, just to go back to the impression. Here we go. And the impression is taken with these caps that slot over and into the implants, and then you would take a silicone rubber impression. But you can imagine you take the impression, you get a little bit of shrinkage or a little bit of expansion, then you pour stone into that and make your models, you get a little bit of shrinkage, a little bit of expansion. But actually, it works pretty well, and you get your final teeth that you can put on. So, in an implant case, you would take your impressions, impression of implant heads. This is clipped around the implant on the left, and then something's clipped inside the implant, and this references the position of the implant to the existing, to the adjacent teeth, so the technician knows exactly where that implant is in relation to the surrounding teeth. So then you would take an impression like this, you would get your stone model. If you want to index how the upper and lower jaws meet, you would have a wax block made, and you would bite into that wax block mark the center line, mark the smile lines, mark where certain teeth are, and then the technician could set the teeth up according to that. So, and then what they would do on the implants, basically they would have these, which are abutments, and these abutments are prefabricated. So because they're prefabricated, you would have to choose the angulations, you would have to maybe trim them and slightly bevel them and angulate them so that they're not interfering with the bite if they were too long. And you would set them up like and parallel them. They'd have to be all paralleled. And then the final bridge would cement onto the top of that. So here we go. We have you know, in this case there are two prefabricated abutments paralleled up, and then the bridge slips on, cements on top of that. Modern day approach. So modern day approach is a little bit different. We can pre-plan the case using the CT scans, and here we have this was an implant that failed actually, I think. This is the nerve running inside the jawbone. There in red, you can see on the left, that's the hole where the nerve comes out. So we need to put our implant here or put our implant here, basically. Initially, I was thinking of putting an implant in here, in this space just in front of where the previous implant had failed. So I saw this lady, I'd seen her and placed implants elsewhere, but she'd already had this implant previously a long time ago. That implant subsequently fell out. She said, can you put another implant? So we can very accurately measure in millimeters the height of bone, the width of bone. We want to keep clear of this anatomical structure here. And we can plan what we do. In fact, in the end, I will say, actually I put it in the previous implant site. But so that healed very nicely without any incident. And when it came to taking our impressions, we don't take impressions now. I haven't taken, well, I do occasionally take impressions, but virtually 95% to 99% of the time I take digital scans. So it's a digital scanner is like a little camera connected to a computer that will record the image in 3 dimensions of the adjacent teeth. It will also record the soft tissue around the implant, and then we can screw into the implant something called a scan flag or a scan body, and that scan body has specific dimensions. It's beveled as well, and a technician will know from that exactly where that implant is in relation to the other teeth. Now, there's no expansion, no contraction as you get with impressions and models. This image doesn't degrade. So, you know, it's very nice. You can send this image anywhere in the world within 5 minutes. So you can use, whether you use your technician as we do, our technicians upstairs, but we send it to the cloud, it reaches them in 5 minutes. But I could send it to, you know, someone in China, for example, and we have the same, the same time. So it works very nicely. And then what happens is they take that image and then they will print a 3D. So everything's designed, sorry, just to go back a step, everything is designed then digitally. So the implant is placed, the analog implant is placed there digitally. Then the abutment is designed digitally, and then the abutment, the models are 3D printed, and the abutment is milled to fit where exactly to the shape and size and position that you would want it. So, and then what the technician does in the end is he does the ceramic work around the outside. So realistically, a lot of it's done digital planning. So he's spending a lot of his time now digital planning. He's spending a lot of time, then he'll print the model. The actual abutment gets sent off, usually a milling center. That will come back, and then he will, in this case, this is zirconia abutment. So the zirconia abutment and the crown is one piece. And actually, so that's why there's a screw in the center of this tooth. And you will, so basically all you do is take off the little screw cap that's there, fit the crown in, it locks into position, take a check x-ray to make sure that it's actually in the right position, and then tighten it up. Now we use torques of Newton centimeters, so that is torqued into place at about 25 Newton centimeters, and implants normally torqued into the bone at about 30 to 50 Newton centimeters. So I know a lot of engineers deal in Newton meters, and they laugh when I talk about Newton centimeters, but that's what we deal with. And then we cover over the screw hole, believe it or not, with PTFE tape, and then we put some white filling material over the top of that. So the nice thing about this is that if for whatever reason I have to take this crown off, I can uncover the screw hole, unscrew it, take the crown off, exposing the implant beneath that. Also, you know, we can actually use titanium as a material. So you can see implant CAD-CAM screw to retain titanium abutments can be made, or zirconia. Generally, I tend to use either one of the two, either titanium abutments or zirconia abutments. Those are the connections that go in, slot into the implant, and that's the screw that goes through the middle, screwing that into the implant. And in this case, this is a stone model with an old analog implant in place, or you can have a virtual model which can then be 3D printed. So this is the intraoral scanner. Now I use commonly a Trios scanner, which is made by 3Shape. Screen is like this. It's just a user-friendly piece of software with a handheld camera, and you can see how it is. Might have a little video there. Yeah, it allows me to play them. So it makes this noise. This is just picking up the image. I'll just allow this to run for a couple of minutes, and then this is what you can see on the screen. I'll just pick up the image. So you get the idea how that works. And what you can also do is you can then take an image and you can do what we call a diagnostic wax up. So the way it used to be done, you take your stone model, the technician would add wax to existing teeth or trim the teeth down and then wax them up. And in this case, this person had some unusual position of the teeth and they wanted some form of symmetry. You can see this tooth sticks out here a little bit and they wanted some symmetry there. And what you can do is you can do this virtually. So you can start to look and then you can turn everything around to make sure you've got the right sorts of positions. And again, it works really nicely. So we use a lot more of this technology now in our planning of cases, basically. And then you can check the bite, so you can use the lower model as well, and you can check how the teeth come together. So we use this along with some photography, and we call it digital smile design. You know, that's a common term, and you can see this is a scanned upper and lower model, and this is the person who it relates to. And what the idea is that when you're making up a teeth, they should, for example, they should be parallel to the line between the two pupils. And obviously we've got the center line. So we've got various lines and then a smile line as well. So it helps us set the teeth up into ideal positions. So we can then do like a digital wax up. So those are the original teeth. Those are the digital wax up teeth. And then we can use that to mill temporary teeth template. And then this is a drill guide. So this is a 3D printed model. This is the milled temporary tooth template. And then this is actually a drill guide, which is showing me where the best places to drill into the bone are to place my implants. So this is this chap without teeth. And this is where we ideally want to put the teeth. You know, again, this is made, we can put this is a bit like a denture actually. You can slot this onto the on some models. So I can actually take this, put this insight in and out of the mouth. And then on the same, so this is the, sorry, you've got some lines across here, but this is upper and lower, ideally how we want to set things up. Even some fake gum can be put there as well. And then this is the final thing actually on the day. So what I did on the day was the remaining teeth were removed, the implants were placed, and then that template that you saw previously, this one here on the left, was then used to fix into position to show the technician where that went against the implants. And so teeth were removed, the implants were placed, and on the same day we placed this temporary, this is only actually a temporary bridge, so a same day temporary bridge. So the chap came in with maybe a not so great looking smile and went out, hopefully, I hope you would agree, with a better looking smile. We did the same with the lower actually. So these are upper and lower temporaries in place at that point. So we did that with the upper and that with the lower. So you can achieve quite a lot with this sort of treatment modality, and it's a very nice way, very slick way, very clean way of doing it, where you've got lots and lots of control over what you're doing. And here as well, you know, just another example of digital wax up smile design. You can see that how it is set up, just in terms of just quite a nice little sweep across, showing before and after how we will want to set the teeth. So this is our template really. This then guides us in terms of the rest of the treatment. So once we get agreement, we can show patients as well. We say, look, this is what we're trying to achieve. They may like it, they may not like it. Then's the time to discuss it, decide exactly what we want to do, and take it from there really. So, and again, we've sort of got before and afters. So these are just another before. This was the case I finished this week, just on when did I do that? Monday. And this was the before, and this was the after case. And so it just shows you, you know, what we can achieve. So I'm going to just switch over and not talk about implants for a while. I'm going to talk about lasers in dentistry. And a few wordy slides. So there are two types of lasers that I've generally used. One is a diode laser, which I don't use so much now, but it's just a small handheld laser, electrically pumped semiconductor laser. Excuse me. Other applications for diode lasers are laser pointers, fiber optic communication, barcode readers. The particular laser we use has these units, 800 to 980 nanometer units. They have a high affinity for pigmented tissue and hemoglobin. So they're absorbed into anything dark, basically, the laser energy, which makes them good for soft tissue applications where there might be some blood there, but also limits some of their applications as well. It's more for soft tissue, simple cases, and we use it also, we did use it for low level laser therapy, which promotes in combination with other treatment. And low level laser therapy is you increase the spot size of the laser, and it's a very low level, so it produces some heat energy, and it promotes rapid healing and reduces things like post-operative pain and swelling. So if somebody has muscle and joint pain in their face, myofascial pain, or even things like cold sores and ulcers, then we can use that to promote increased and rapid healing. It's a very nice tool actually, but often sort of misunderstood or not quite appreciated. But I'm just going to show you here, because I can't really show you that, just a simple case here. This person came in. If you look at the two teeth here, this tooth is a little bit shorter than this tooth. They had some orthodontic treatment. They wanted to perfect, if you like, the shape of their gum. So there are only small changes, and you can use the diode laser just to recontour around the gum tissues, just to try and get that symmetry and make things look nice there. So this is the sort of thing you might use a diode laser for. Or a soft tissue problem here where they've got a gum overgrowth and you have to remove that gum overgrowth and recontour the tissue here. Now this isn't a burn, actually, this brown stain. This is actually propolis. For these sorts of treatments, we tend to put propolis over the wound site, and propolis is a product made by bees, which has a very good healing and antiseptic properties. So we use it, it's a great material you know, you can get hold of it. You can take propolis tablets, I think, but you know, it's really good material if you have a cut or something like that. To put some, if you take anything away from this talk today, if you can get hold of propolis to put on cuts and scrapes and bruises, it's actually quite a nice material to use, quite natural as well. But what I tend to use, bulk of talking about lasers, is a Waterlaze MD, which is a YSGG laser. It cuts both soft and hard tissue. It cuts without heat as well and seals blood vessels as it cuts, which results in less pain and post-operative sensitivity. I had a lady come and see me today with quite a severe swelling on a little bit like the one that you just saw, a little bit like this one, but much more severe, about sort of 8 times the size of that. And she specifically came to see me because she knows that I use a laser, wanted to use the laser because in her mind she's thinking I'm going to get less pain and better healing with it. A little bit of it, it's a hydrokinetic system. It's erbium, chromium, yttrium, scandium, gallium and garnet. Those are the crystals involved in the laser. All different types of lasers using different types of crystal systems. Shallow depth of tissue penetration, which is good because it means that the diode, if we have to use, you know, be very careful how we use the diode. We have to black out all the windows. No one can come in the room. Patient has to wear special glasses. We have to wear special glasses. If you shine that through a window, it can go across the road. If it was to hit somebody in their eye, consequentially, it would damage their eye. So, you know, a diode laser is like that. A Waterlaze MD, as long as you don't hold it less than 5 centimeters from your eye, you are fine. It will actually not do anything to your eye. But we still take precautions because we have to. You know, in this day and age, health and safety is we might, you know, it doesn't have any. There's no problem taking adequate precautions. But it has a shallow depth of tissue penetration, lack of thermal damage, mineral reflective properties, and it's pulse beam and fiber delivery. And what it is, the energy is, it's me, you know, hugging the Waterlaze proudly. This Waterlaze, the energy, it pulses water and the energy is absorbed into the water. So the energy produced is absorbed into water, and that's how partly how it ablates soft and hard tissue. All laser systems act by ablating tissue, by destroying tissue, whether that's hard tissue or soft tissue. And there we are using the laser in the surgery. It's got a very fine tip. The tip can be end or radial firing, which is quite useful. So if you want the laser energy to spread out a little bit, then use a radial firing tip. If you just want it very pinpoint, use an end firing tip. It's minimally, you've got fine tips, minimally invasive. So you can avoid sometimes surgery and stitches, quicker healing, less pain and swelling, less bleeding. Soft and hard tissue removal, you can use it for gum treatment, crown lengthening, like you saw the gum reshaping, some soft tissue surgery, and peri-implantitis, which is diseases around implants, I'll talk about in a little bit. So a frenectomy is this tissue here, which connects the gum to the lip, basically. And you can't see it so well, sorry, not the greatest slide in the world, but actually sometimes what this does, it creates a pull on the gum and causes recession. So what you have to do is remove this tissue, and in the past I'd remove it surgically with a scalpel, clean the tissue out and suture across there. Now I'd actually remove it with a laser, and I wouldn't put any sutures, or maybe hardly any sutures in there. So it's it makes the healing actually a lot better and easier for the patient. That's just carrying out the frenectomy. You can see there's the water laser tip. You cut a diamond-shaped incision here between the connection of the frenum from the gum to the lip itself, and there we have it cut there, and it can just be left thereafter. Crown lengthening to reshape the gum tissue. We're going to replace these. We're going to crown all these teeth, but they're short, stubby teeth, not enough tooth tissue for retention. So you actually have to reshape this tissue and do that. And just this is another surgery, just showing the laser in action here. working his way around the soft tissue. So what you can do is shape the soft tissue, and then what you actually have to do is also shape the you have to shape the bone as well. So I just see that you have to shape the gum tissue, and then you have to shape the bone as well. I can see the subtitles are going nuts at the moment, so sorry about that. You can't hear very well. So you shape the bone as well by changing the settings. So in that way, if you didn't shape the bone underneath, then the gum would just grow back to where it was, because the actual position of the gum is reliant on the position of the bone underneath. So that's just showing you that it's a very nice way to do it. Normally I'd have to do this surgically, cut the gum and lift the gum back, drill away the bone, reshape it, and then put the gum back and then tape it up. So basically, sorry, I think that the subtitles didn't like the noise of the laser behind that. So, sorry, but normally what I'm trying to say is that you have to reshape the bone as well as the gum, and that's what the laser was doing. You change the settings in order to do that. Without reshaping the bone, you can't get the gum tissue to stay where it is. It just grows back because it's reliant on the position of the bone ultimately. So you can also use the laser to get down between the gum and the tooth, and to clean inflamed tissue where there is actual gum disease as well. And the next little bit of clip of video will just show that. I won't dwell on it for too long because it actually looks quite similar to the one clip that you just saw. So that's just using the laser. So that was just using the laser to get down between the gum and the tooth and to clean inflamed, infected tissue down between the gum and the tooth. If people have small polyps and things like that, you can remove them as well. So you just grab hold of the polyp. It's a fairly simple, numb it up, of course, first, grab hold of the polyp, and then you can undermine it and remove it thereafter. And this is quite an extreme case. This lady had quite a significant, as you'll see, growth on her lip, on the inside of her lower lip. And it's a fibrous growth. You might look at that and think that's some terrible tumor, but in fact, it's actually a big fibrous growth that was caused by a poorly fitting denture. And we brought her in stages to remove a significant amount of this tissue. It's just interesting to see what you can. So you can see me gripping that, pulling the lower lip back and gripping. There are no teeth involved. There are no teeth there. Pulling the lower lip back, and I'm undermining that growth with the laser. And the laser was great to do because if I tried to do that surgically, it would result in loads of scar tissue and a very big wound surface that would bleed. If I used a scalpel blade, it would bleed a lot, and bleeding control would be very difficult. But using the laser was the perfect tool for this job. I'll show you a bit more. So you can see that and all this behind here is growth as well. So I had to remove. It's going to do the whole lot in one go. I think we removed it in 2 to 3 stages, but we had an amazing result with it. And it just shows you. I'll sort of click on the video a little bit. Just shows you what we. It doesn't remove it quickly. It takes a bit of time. You have to have a little bit of patience with it. But as I say, if you have some patience with it, you get a nice result from it. Okay, so similarly, this was a lady who attended the clinic, an elderly lady who I think was suffering with a bit of memory loss. She had a denture that was connected to these. So sometimes people have dentures called an overdenture. You have an implant, an implant, an implant, and an implant, and then there's a bar that connects to these implants, and then a denture clips on and off of the bar. And obviously it helps to keep the denture in and retain the denture. But this lady had worn this denture, and she thought, she didn't realize for many years that you could take this denture out. And as a result, you can see this, you know, it was really not very nice around there. This actually cleaned up quite a lot. But this tissue had become hyperplastic because of that. And she couldn't fit her denture in anymore because she took it out and then she couldn't put it back in because of all this overgrown tissue. So my job was to remove this tissue. And again, because of the amount of wound surface, laser was a great thing to do that. So the laser completely recontoured this top jaw gum tissue. So it's just showing you what we can do. I also use the laser to fix problems around implants in conjunction with other treatment. Now, implants, you can see this is an implant bridge, and underneath here is the implant connecting the bridge to the gum. And you have to get under there and clean it. But some people can't do that very well, or don't do it, you know, for whatever reason, they develop a form of gum disease around that implant, which results in a loss of tissue and bone. And this is what can happen when you lose that. So these are the implant abutments, but you can see here there's a bit of pus coming through there, a bit of pus coming through there. If you lift the gum back, then you can see actually there's loads of bone loss around that implant. You actually have, because remember I was saying that you have bacterial contamination in here. You can't clean that very well, especially with a roughened surface implants, which what most implants are nowadays, to increase the surface area to allow the bone. You actually have to you have to remove the screw threads and polish that implant up and accept that that part of the implant is not going to be helping holding the tooth in place anymore, but what is underneath that is going to be holding the tooth in place. So you can see that cleaning that out, removing the threads is important. And what happens is that obviously you get some polished screw thread or polished implant exposure, but the ability to clean around there is immensely more easy than what it was before. So we can use the water lathes to do this. So normally I'd have to cut the gum, lift the gum back as you saw on the previous slide and do that. But with the water lathes, I've been able to treat some quite severe, you can see these were quite heavily threaded or implants that have developed disease around them. This is a draining, we call it a draining sinus, pus is coming out of there, very inflamed gums. And using the water lathes just to trim back the inflamed tissue around there rather than lift a big gum flap and do some quite major surgery. Then I was able to access around, so resect the tissue and then access around the screw threads and then smooth those screw threads off like that. And then you just allow that to heal. And then that's the sort of result that you get around that. So it just shows you, you know, some applications of the laser. There are some other things that we do, but as well, which we can talk about if anyone's interested after the end of the talk. So we're going towards the end. The last thing that I wanted to talk about was some CAD/CAM, chairside CAD/CAM solutions. So we can do fillings, we can do crowns and bridges, we can take an impression of this, or we can do a scan of this and send this to the technician, so we can, for example, replace these amalgams with white coloured porcelain or ceramic inlays or onlays or a crown, and we can either scan those, send those to technician can make them, or we can scan them and mill them ourselves and put them in on the same day. And this is the sort of thing that you can do. So sort of go back, this is the machine that we use is called a Cerec Machine. And this is, the machine comes as one unit. So this is the acquisition unit, and this will be a camera on a unit with the software here and the screen. And what you do is that you capture your image and then you define exactly what you want to do, the parameters by which you want to make your inlay or your onlay or your crown, and then that will send you put a block into a milling machine and send a signal to that milling machine, and the milling machine will cut the block into the shape that you want. You will then, with a little sprue, you take the sprue off, fit the inlay or the onlay or the crown, polish it up. You can put it in a furnace to stain and glaze it and harden it, and then cement it on or in. And what we used to do, the old machines had a contrast medium spray, so you'd have to actually spray the teeth with a powder, and then that would help the scanner to pick up the definition. But we don't have to do that now with these new machines, these Omnicams. So these are made by Sirona and they're called Cerec machines. And you can also use them for implants as well. I tend not to use the Cerec machine for an implant. I tend to use them for sometimes for crowns like this, and sometimes for inlays and onlays, as you saw in the original slide. So you define your crown, where the margins are, and then you can adjust the shapes of it. It will give you what they call a proposal, so a shape. And then if you're happy with that, then you can mill that. So you can define, as I say, you can set in the parameters of exactly what shape you want. So that's the milling machine, and what you can see is you can see a block of material, a ceramic in that milling machine. There are two burrs, and once the signal is obtained here, then that milling machine normally takes about anything from 5 to 15 minutes to mill a crown or an inlay. So there it is, cutting the porcelain block. You can start to see the tooth being milled. It uses a lubricant, a sort of oil-based lubricant to in order to keep it cool, to stop either the drills from getting too hot, damaging the ceramic. And you can see the crown's taking shape then, and that's sort of virtually the finished crown. You end up with a sprue between the block and the crown, where that needs a bit more cutting, if you ask me, and then and then the sprue just is removed. And then that's the final onlay once it's polished up, or you can, as I say, stain and glaze it, put it in the furnace for cementation. So that's sort of an overview of a lot of the things that I do. Say I'm a specialist, gum specialist, but actually what I do lots of general dentistry. I place a lot of implants, do lots of overall restorative procedures as well. So it's just showing you how I use technology and how I have to thank physics, really, or the application of physics for the technology that I can use today to help me perform, if you like, reliable and high quality dentistry for the restoration of function and aesthetics for my patients. So that's pretty much the end of my talk today. If you have any questions, I'll put the, do I stop sharing the screen now? I think, and I'll put it over to Rizwana to manage that. So thank you very much for all your kind attention today, and for actually listening to me. I'm very grateful for that. Thank you.
Well, thank you. That's amazing. I worked on the lasers. My mother knew Professor Gabor, Dennis Gabor, and my father, my uncle was a student of Dennis Gabor, PhD student. So to see this now, I wish my mother was with me. It would be amazing. Now, questions, Amy, have we got any questions? Because my mind is just burning. What I would like to ask is, where do you think we can, sorry, did you say something, Amy?
No, it's okay, go for it, Riz.
Yes. Where do you know, it's come such a long way. So where do you, I worked with lasers. My research was on ray tracing through holograms, which is just ancient history, ancient techniques, I mean. Where do you think we are going? I mean, what's the latest research for teeth and dental? I mean,
the low-level laser therapy stuff's quite interesting, especially with regards to myofascial pain. So reducing pain post-operatively, improving quicker healing times post-operatively. I think there's a lot of interesting research on the use of the low-level laser therapy. Also, I think that what people do as well is that they there's a lot of fluorescence laser being carried out. So what that is that you can inject dye into fluorescent dye into it, so between the gum and the tooth, and what you can then do is activate that dye with a laser, and that will kill bacteria. So there is a certain movement towards gum treatment where using fluorescent dyes and then activating that dye to kill the bacteria. So there's that sort of laser therapy as well. And I think other than that, it's trying to refine the existing lasers. The problem with laser dentistry is actually the startup costs are very high. So to buy a laser unit, you're talking about 40,000, 50,000 pounds. Like that Waterlays MD, is I think 40,000 pounds, 50,000 pounds. Most people buy a second-hand refurbished one and then and work with that because the startup costs are really high. And also the other thing in laser dentistry is there are different types of lasers, and those different types of lasers can do slightly different things. So there's marketing by different companies. So rather than, it'd be nice to have a laser that can do everything, rather than have to buy, 3 40,000 pound lasers that can do slightly different things and a lot of the same thing. And then finally, there is actually a bit of politics in laser dentistry as well, because you've got two main schools in Europe. You've got the German school and you've got the Italian school. So, and they both teach in different ways, and they have different training pathways, and you can get training, through the Italian school, you can get training through the German school. And so rather than bring the laser community together, it's sort of polarized it. So those are hopefully those obstacles can be overcome. We've got quite a nice laser community in the UK, dentally wise, which is quite nice actually. So
thank you. We seem to be right out of time. This was the last of our lectures in the summer series. The winter session of 2021 will start in October. So I can, it was amazing. I mean, I can only thank you. Thank you for your time. Thank you for the effort. Thank you for putting together. Thank you for, giving up your time to rehearse. It all takes time, out of your day. And we're really, really grateful. I'd love to have you back, it's such a fascinating topic really, because we all have teeth, and some of them are still there. What I would like to say is, first of all, thank you. Secondly, please, can the people who are still listening, can they go to the website, keep an eye on it for the rest of the lectures? And I'm going to ask, be on people's backs and say, please, can you send in any questions that you would like to ask, and then we can source the speakers. So we have to end because I think we're running out of time. It's 6 minutes past 7. And thank you, Dr. Craig Kennett. So grateful, from the Institute of Physics, London and Southeast branch, and all the audience. Thank you very much, and a virtual clap for you.
It's a pleasure. It's a pleasure. Thank you.
Thank you. Thank you very much.